Let's talk now about the costs of care and how to reduce them. Since about 70 to 85% of claims paid go for chronic illness and other catastrophic care, then the logical place to address costs is here. Consider these two examples of good physicians doing their best, but in the end not giving the best possible care. First is Henry. He's in his late 60s, he's overweight, has high blood pressure, heart failure, diabetes, depression, and he was recently admitted to the hospital for a severe sepsis. That's a bad infection that goes to the bloodstream. The latter was treated in the intensive care unit successfully. This is where American medicine really shines. He was near death's door, but he was pulled back. He called me to say that he was now on 23 prescription medications. Yep, 23. To shorten the story some, he was on 3 for his high blood pressure. He told me he had 4 doctors, and each would make adjustments to his blood pressure medicines. His blood pressure was always high in the doctor's office, but when taken by his son, who was an emergency medical technician, it was always normal. I thought to myself it was probably white coat hypertension, where it goes up in the doctor's office but not all the time. Well, there were issues with his other medications as well, but for now, the question was, did his 4 doctors talk to each other? Did they share their records among themselves? Henry told me, no. I suggested he needed a primary care physician to coordinate all of his care. Once he found one, his total meds were reduced to 7 from the prior 23. He now felt better, and he was saving a lot of money. And by the way, so was his Medicare Part D insurer. This is a fairly blatant example of how the lack of care coordination leads to many medications, some of which cause some severe side effects in Henry, but that's another story. For my second example, consider Sophia. She does have a primary care physician, one that she's gone to for more than 20 years. Now, she always tells him that she feels tired and fatigued. He's never been able to find a medical explanation for that, so he just understands that that's what she's going to say. But then she developed what we'll call episodic bradycardia, or a slowing of the heart rate for a few moments. She would black out and she would fall. So a pacemaker was put in, and she was now fine since it detects the slowing and overrides it immediately. But one day she was elsewhere and went to a different internist for a minor issue. He had only a few minutes to see her. He heard the usual complaints about being tired and fatigued, and he knew she had a pacemaker. He put 2 and 2 together and he got 6. He didn't have time to explore this with further questioning, so he sent her to a cardiologist. The cardiologist heard the same story, thought it might represent heart failure, and suggested what's called a dual lead pacemaker. Wasn't needed, just wasn't needed, and it's very expensive. She didn't need this expensive dual lead pacemaker because she didn't have heart failure. She had an electrical problem, not a mechanical one. So this is another instance of where the internist was quick to refer to a specialist, and the specialist in turn was quick to make a judgment. But this would not have happened if her primary care doctor had been consulted first. These 2 examples are illustrative of what happens today. The primary care physician is too busy to fully explore an issue, so either makes a judgment and adjusts medications or sends the patient to a specialist when it's just not necessary. This drives up the costs and it lowers the quality. Related to this issue is prevention. Sure, primary care physicians and other physicians do spend time giving immunizations, do perform screening tests for blood pressure, cholesterol, and cancer, but they generally don't spend the intense time needed and the effort needed to work with the patient on the lifestyle issues that are increasingly important to later health status. There are many reasons why medical care costs so much and is rising so fast. We tend to hear about the following in the media and other locations as being the major culprits: new technologies or new drugs, malpractice costs, fraud and abuse, or simple greed by the doctor, the hospital, the device manufacturer, or the insurer. And yes, some of these are important, but they are not the key factors. Here are the real culprits. More and more people with chronic illnesses. Let's just put that up at the top. These diseases, as I've mentioned, like diabetes or heart failure or cancer, are complex to manage. They often last a lifetime, They're inherently expensive to treat. We know that most of the healthcare dollars go to treating these patients, but they tend to cost more than they need to for a variety of reasons. Chief among them are the overuse of specialists, tests, imaging, procedures. To a large degree, as I've mentioned before, this is because primary care physicians have too little time to sort through issues on a short office visit, so they're quick to refer out to a specialist or to order a test or an x-ray. Now, of course, when the patient is seen by the specialist, the tendency is to be thorough and perform whatever tests might seem appropriate. What these patients really need is good care coordination. When that happens, there is less use of expensive drugs, less testing, fewer visits to the specialist. I gave an example of a patient given 23 drugs by 4 different doctors, but once he had a single physician paying close attention, he ended up on 7 drugs instead. Better quality, less costly. There's also an overuse of drugs when lifestyle changes would do the job. Consider acid reflux or GERD. We're taught from TV ads to just ask the doctor for a prescription. But the first step is the following. Cut back on alcohol and caffeine. Raise the head of the bed so the acid won't ride up. Eat less spicy food. And don't go to bed for at least 2 hours after dinner. These are straightforward, they're fairly simple. But some people will still need a drug called a proton pump inhibitor. Your doctor may give you a prescription for a brand name one still on patent. It might cost about $150 for a 2-week supply. But no problem, you only have to pay about a $15 to $20 copay. Your insurance will pick up the rest. Of course, you could go to the supermarket and get a nearly identical drug for about $28 over the counter. What would you do? Well, probably you'd get the more expensive prescription because that costs you less, the $15 to $20 for your copay versus paying the whole $28 for the other one. This is an example of our really dysfunctional incentives in American medicine, which in turn brings us to some very straightforward ways to reduce healthcare costs. First and foremost, patients with chronic illnesses need good care coordination. They also need a multidisciplinary team anchored by a physician who does the coordinating, the orchestrator. Prevention is key as well. These are largely diseases due to lifestyle factors such as poor nutrition, lack of exercise, stress, and tobacco. Again, a good primary care physician can be a big assist here. But the current business model for primary care physicians just doesn't work. So one of 3 things is going to happen. Insurers, including Medicare, will have to begin to pay primary care physicians more so that they can take the time needed with their patients who have chronic illnesses. Absent that, primary care physicians will probably increasingly opt out of insurance and either bill per visit or switch to retainer-based practices. Both of these will work. There are some other options as well. Enrolling patients in accountable care organizations, that's a fairly new concept, but the accountable care organization makes use of the so-called medical home concept. These are just getting started, but they have promise. Time will tell how well they'll work. What else can be done to prevent these chronic illnesses from happening? One of the best approaches is company-sponsored wellness programs. The company sets up nutrition, fitness, stress management, and smoking cessation programs. Employees are invited to volunteer to participate. In return, they get a reduction in their portion of the insurance premium. This can be rather substantial, and it serves as a good incentive. These programs really work. When properly instituted, they have meant no increase in total healthcare costs or premium costs over a period of years. In some cases, costs have actually fallen. Plus, with a healthier staff, productivity may go up and individuals are more satisfied with their jobs. Overall, it's a win-win. High-deductible insurance policies are another good way to slow down the costs of care. Today, we have mostly prepaid medical care. By that I mean that our insurance covers just about everything, including routine visits, most medications, and testing. In the past, insurance was for the catastrophic, for surgery, for a hospitalization, but we paid for the routine, but not anymore. We need to go back to true insurance, just like our auto collision insurance. You can have a low deductible and pay more, or a high deductible and pay less. Same thing in medicine. When individuals have a high deductible health policy, let's say $1,000, the premiums are much lower since you're now really paying for true insurance against an unlikely event. And high deductibles have a side benefit. It gets us involved in our care decisions. Now it's our money, so we ask questions. Remember that $150 prescription for acid reflux versus the $28 over-the-counter drug? Now we'll choose the much cheaper one, and that's good all around for the healthcare system. And if our physician suggests that we have an MRI, we'll be inclined to ask if it's really necessary. It may not be, but in the past we never bothered to ask. And if a cardiologist suggests a very expensive pacemaker, as in the case I described before, we'll be quick to call our primary care physician, find out if this is really necessary. Some would say that preventive care should be included with no deductible or copay. Personally, I'm not so sure, but if that's the choice, these can be excluded from the deductible. But it is important to remember there's no free lunch. If it is part of our insurance, then the premiums will have to be sufficiently higher to cover it. Pay now or pay later. The high deductible also brings us back to a more typical professional relationship with our physician. We're now paying for most of our care directly, not via an intermediary. The doctor will know we're the one paying, and this adjusts the relationship in subtle but very profound ways. Bottom line, high deductibles make good sense. It gives each of us an incentive to ask more questions and to challenge our providers, and that's a good thing.